Hi everyone, I'm Dr. Faisel Sayed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care. Today, we're talking to Dr. Yalda Jabbarpour from the Robert Graham Center about Primary Care Scorecard, the cost of neglect. Let's get started.
Hello, Dr. Dan.
Hey, Faisel, how are you?
Oh, I'm doing well. Dr. Jabbarpour, it's good to see you.
Good to see you. How are you today?
Oh, doing great.
Good.
Doing great.
Awesome.
And very excited about this conversation. You've been such an influential voice advocating for strong primary care. And now with this 2025 scorecard out, let's get started.
Yeah.
Can you walk us through, if you had to pick like the most critical finding that shocked you the most?
Unfortunately, nothing shocked me, which is sad, but I would say the most critical finding, so the title of the report is The Cost of Neglect. So I guess it makes sense to say that the most critical finding has to do with how much we're investing in primary care and how we're paying primary care. And so I would say the first three figures, if you're looking at that report, are probably the most critical, where our primary care spend figure shows that we're only spending 4.7 cents of every dollar on primary care. And then because of how our payment system is set up, and which is mainly fee for service, which obviously does not completely value all the stuff that we do in primary care, we have a figure that just demonstrates that, showing the differential revenue generation in our current fee-for-service model between primary care and a more procedure-based specialty like gastroenterology. And probably not surprised to you guys, but primary care in the current fee-for-service system only generates 1/5 of the revenue that gastroenterology brings in. And so, it all flows from there. So it really is all about the money this year.
We're seeing like all this attention on the news with the emergency room, hospital care. I was just in a meeting with our insurance partner, with the company I'm with. Unbelievable costs around and even visits with the emergency room. Numbers that like never seen before. I mean, it's unbelievable. So what would you say the biggest barrier would be to making sure that we as primary care doctors are properly supported and reimbursed for the work that we do with providing whole person care?
I think it's a great question. I mean, I think the biggest barrier is how our payment model is set up. Right now, we don't get reimbursed for all the interstitial stuff that we do that is so important as primary care. The continuity that allows us to know when a patient is really sick and needs to go to the hospital or when they just need reassurance. That comprehensiveness of care that we provide so that busy patients don't have to go see 5 specialists. And in the meantime, maybe their condition gets worse and they end up in the ER. They could just get it all done in our office. That coordination of care that we provide to follow our patients in different settings so that we know when, 2 specialists are maybe giving treatment plans that might interact poorly with each other. That stuff that is just so important to the care of the patient, we all know this, is just not adequately reimbursed in our current system. And that is the biggest barrier, because it's not about putting more money in the pockets of primary care physicians. It's really when we're not reimbursed appropriately, we have overburdened offices, overworked physicians, and that in turn impacts access for patients.
Although when you were talking about revenue generation, I just would like a call out. Having moved from a full risk model back to a fee-for-service model, we're talking about revenue generation in a fee-for-service model. If you were looking at revenue generation in a full risk model, I can assure you the numbers would be flipped. It would be the primary care doctors would be the revenue generators. Then the gastroenterologist would be a cost center. They wouldn't be a revenue center. They would be a cost center. So for our colleagues still working in the full risk model, we want to make sure that we call out the difference from that.
Oh, yeah, absolutely right. Yeah, I'm talking about the traditional fee-for-service model, which unfortunately most of us are in still. That is most of how we all generate revenue right now.
Well, and I was thinking, I know you brought out in the report the impact of the EHR and the inefficiencies of the EHR, but it's interesting what I'm seeing where I am is they have come out with ambient AI, but they're only so far, they're only giving ambient AI to primary care. Because the super subspecialists have been paying for human scribes. Primary care hadn't been able to afford that. But this is a lot like the Clayton Christensen disruptive innovation model, right? I mean, you first got people using these crazy little toys that turned into personal computers that then completely disrupted the computing industry. So now, if I'm having ambient AI helping do the office, and that's giving me the additional time I'm able to use AI to help manage the medical literature, because most people who went into primary care went into it because they didn't want to give up doing things. And now you're able to stay up to date more. I'm just wondering, can this be a disruptor going forward? And can primary care finally start disrupting the entire healthcare system this way?
Absolutely. I think it's a great question. And we do feature, we're not trying to be completely negative in the report. So we do feature case studies of places where things are going well. And one of those features is around AI. And we feature, two different places that are doing AI. One where there's been a lot of financial investment into it at the University of Rochester, and one just a small residency where, the residency program basically just paid for, kind of one of these emergent AI scribes, and they were able to afford it. And I think you're right. I have the ambient AI in my office right now. I think it's a lifesaver, really. I think it is a positive disruptor. I think what's going to be important, just as it was important in the rollout of EHRs, but I don't think we did it enough, is that primary care really needs to be at the table in designing and deploying these ambient services, any AI service. Because what I fear is if we're not at the table at the health systems, really making decisions on which AI should be chosen, how that AI rollout should happen, what features of the AI we should use, it's again going to become something that is not beneficial for primary care.
Very excited about all the innovation that's coming with AI, but I agree. Like, we have to be the ones who are driving it. I'm seeing it firsthand at City Block with AI being used for all the case conference prep work that the teams used to spend so much time with getting everything all together to present these cases to us. But now with that, I mean, it's amazing. But we have to be the ones who are driving it. And so what I'm looking forward to with all this is the resident and the medical student, especially the medical student experience as they're doing their rotations through, that this gets rid of a lot of the busy work that gives family medicine, it gives primary care, that doesn't give them that. We run across students and residents saying, I'd love to be a family doctor, would love to be a family doctor, primary care doctor somewhere out, but then they don't have a pleasant experience. Many of the rotations are still fee for service. The full risk or the stronger value-based care organizations, they're for-profit. So the students with heavy student loan debt, they don't get the benefit of getting the loan forgiveness and all that stuff. So they're not getting to work. They're not getting that real experience in a lot of the places that have the flexibility. With the decline in the number of primary care doctors, what do you think we need to do to bring more into the fold?
I think you're hitting on it right there. I mean, number one, we need to improve what's happening in the primary care office, because you're right. If a medical student rotates through our primary care office and sees these, overburdened, overworked primary care practices, they're only human. They're not going to say, oh, yeah, I mean, yes, I want to go into that. No matter how much I love family medicine, I don't want my life to be that way. I also think, though, it starts with how we're investing in training. And this is another figure that we have in the scorecard right now. As you two know, a majority of our training happens in academic medical centers and happens in hospitals. We also know that a majority of GME funding comes from CMS, from Medicare specifically. And our question was, is that funding really resulting in a primary care workforce? The whole point of Medicare investing so much in training is to make sure that they have a workforce that can take care of their patients. And that would be primary care, right? I mean, who else is taking care of older patients with multiple chronic diseases? Unfortunately, what we showed is that there is a negative association. So the more your state gets in terms of Medicare GME funding, the less production of primary care 2 to 3 years later. Now, are we saying that CMS should stop investing in medical education, graduate medical education? Absolutely not. I think the point that we were trying to make is that the way the money is flowing right now, which is from CMS to hospitals and academic medical centers, is not conducive to a training environment that's going to incentivize medical students or residents to go into or stay in the case of internal medicine, primary care. So I think if we could shift that funding to community-based programs, if we could shift that funding to programs like teaching health centers in some way, or even if we don't shift the funding, but we have health systems feed back to Medicare some sort of accountability that shows that, yes, you're giving us this money, and look, we are producing a workforce that can take care of your patients. I think that would be a step in the right direction. But, we don't have any of those things right now.
But it's not a matter of graduating just in what are called primary care specialties, which is internal medicine, pediatrics, and family medicine, but it's somebody who's actually in an office taking care of patients 3 or 5 years later.
That's exactly right.
Carrying a panel of patients. Now, it was interesting. You mentioned in the report some medical schools. We've heard some of the schools have become tuition free, and that really hasn't made a huge difference in most cases. But you did give some examples of some medical schools that were doing some interesting things that were getting more people to go into primary care. Well, can you elaborate on those a little bit?
It all comes back to the mission of the medical school. I don't think it has as much to do with free tuition. Sure. Absolutely. I think primary care physicians should get free medical school, right? We're doing such a service for the community. I'm not advocating against that. I think all physicians should get free medical school. But you're right. What we have seen is that tuition free does not equal more primary care. And what these medical schools are doing is they are mission driven. They are creating a mission from the top that we want to produce primary care. And that makes such a difference. How they implement that differs from medical school to medical school, but having that mission, having leadership buy into that mission, having, primary care longitudinal tracks, making primary care seem like a career that their medical students should be choosing is really important. Unfortunately, a lot of medical schools right now, there's quiet bias around primary care, against primary care, and making their students feel that primary care maybe is not the specialty for them. And I think these medical schools just stand out because they are so mission driven.
Even politically, with the policymakers, they're pumping out more. Like, they're so used to the sick care way of just everything revolving around the chief complaint. It's like, let's have more nurse practitioners, let's have more PAs. I think there are like now over 300,000 nurse practitioners. So even the policymakers, how can the primary care advocates make their case to the policymakers? Many of these policymakers are still stuck in the old model.
We have an opportunity right now with the administration's focus on fighting and preventing chronic disease. We are the people who fight and prevent chronic disease. So, for all we want to say, I think we can use this moment as an opportunity to say, hey, that's us. Here's the data that's us. You want to lower healthcare costs overall. Don't focus on sick care. Focus on prevention. Focus on well care. I think something else that you said that was really interesting is this, growth of nurse practitioners and PAs. And I do think that we need a team to make primary care happen. And we were hopeful that nurse practitioners and PAs could be part of that primary care team and help bridge kind of that shortage that we are seeing. But as you saw in the report, unfortunately, the numbers of nurse practitioners and PAs going into primary care is also falling. Only about 30% of nurse practitioners are actually practicing in primary care, and less for PAs. And it probably goes back to what we talked about at the top of the hour. It's these market forces that are driving physicians away from primary care are also driving NPs and PAs away. So I don't know that that's the solution anymore.
Most of the NPs and PAs are trained in primary care, and then that throws all of our numbers off, right? Because when you look at the attribution, it looks like we have more primary care providers than we really do, because most insurance companies, when they attribute patients, they attribute them to primary care. And so, again, I'm at the University of Virginia right now. Almost all of our APPs, insurance companies are attributing the patients they're seeing to us for primary care, even though maybe it's in cardiology or they're seeing them in renal. And while those APPs are certainly capable of providing primary care, those settings aren't set up for primary care.
That's exactly right.
So we know that primary care physicians are the one specialty that can improve outcomes and lower cost. And we know that the current administration is desperate to decrease cost in the government and costs going into programs. So I'm sure they're throwing money at primary care research right now to figure out how to do this and do it well, right?
Was that a question that's supposed to be answered?
No. So what's happening with primary care funding for primary care research?
Yeah, I mean, abysmal, and probably only going to get worse, right? When we looked at it for the most recent year, so that would have been 2023, where the data was available. When we looked at NIH, FDA, CDC, HRSA funding, it was, again, less than 1%, 0.34% to be exact, spent on primary care research. So that's disappointing, right? Because we know it's the one sector of healthcare, as you said, where more is actually better, but we need to study models to understand what type of primary care works. There are so many different models of primary care. Some work better for patients than others. Some work better in terms of implementing actually high quality primary care than others. But we need to study that. We need to know what's working, what's not for what communities, and we just don't have the funding to do it.
I mean, you're front and center right there, seeing all the systemic challenges there at Robert Graham Center. For someone like you who's there in this all, I mean, what's giving you the hope that we can turn things around despite all the uphill battles we're facing with the financing and the access?
I mean, I think I say this every time, but I have a little bit of a new answer. There's two things that give me hope. One really is the medical students and residents. I mean, they have so much energy. I think they are much more social mission driven than maybe previous generations. And I hope that will start translating into, we're going to go into primary care. I guess it just remains to be seen. But the medical students that we've had rotating recently through primary care have been very gung-ho primary care, which for Georgetown is very different. I mean, it is not a school that produces primary care. So to see that even at Georgetown is heartwarming, and I hope it translates into a workforce that we need. But the second thing is the AI. I mean, I wasn't sure about it, but after using even just the basic form of AI, which is the ambient listening, just to see how much easier my day has gotten is unbelievable. And I know that AI has more power than just ambient listening. So I'm hopeful maybe 2-3 years from now, all these little administrative things that we have to do that you do not need a doctor to do will be taken care of. And that would make our lives easier, right? We all love seeing patients. It's not that we don't love seeing patients. It's the other stuff that we don't love. And I don't need you to increase my salary. That's not what I'm asking for to stay in primary care. What I'm asking for is more time with my patients and get rid of things that an MD does not need to be doing.
If somebody does increase your salary, you'll take it.
Of course. But I do think that that's not what's driving most people out of primary care, right? It's just all this other stuff.
I agree. Although, the one thing now there was, and am I interpreting it wrong? I know we're losing ground as far as the number of people going into primary care, and we're losing primary care in the community. but the rate of decline was actually less in areas with a high social deprivation index. And to me, that is a bright spot.
Yeah.
But I don't know why that's happening. But can you elaborate on that a little bit?
Yeah, so you're right. What we found was the density of primary care in areas with more social disadvantage or social deprivation was higher than the density of primary care in the more advantaged areas, which was a little bit of a surprise. And we've continued to see this over the last couple years of the report. And we really think we haven't studied it yet. We do need to try to figure this out. But what makes intuitive sense to us is that it has to do with the community health center movement. Community health centers are mostly, if not all, primary care, and they are located in areas of high social disadvantage. So that is a bright spot, that we've, as a country, invested in community health centers. I think it's made a difference for patients, but in the numbers, I think that's what we're seeing.
And the other thing you may want to look at is the Chin Meds and the Oak Streets and the groups like that, where because there is a financial incentive in the Medicare Advantage world to go where there are underserved populations.
Interesting.
I don't know whether there are enough of those people working in that would show up in your numbers yet or not, but that is the interesting thing there.
I also think primary care physicians, we just are mission driven. And I mean, I don't know one primary care physician who hasn't spent at least some of their time practicing in a socially disadvantaged area. That's kind of, for lack of a better term, our bread and butter patient population. That's who we want to work with. And so I do think all of us spend at least some time there, and then some of us get burned out because of all the social needs that are not met that we can't meet as physicians and move to other areas. But I think that explains it somewhat too.
I think the thing that many of us in like the Chen Med Oak Street world, who were there, I know Chen Med was not dependent on investor money, private equity money. I think that for so many years, we had such broad bipartisan support that, hey, we're intentionally going into underserved neighborhoods, focused on it. I wasn't worried. I never thought that we would end up, the whole value-based care movement could get thrown out that because of, being equated like, hey, this is the government versus private equity and all of that stuff. Now that we've learned that, hey, it did happen and the whole value-based movement took a step back, I feel like as we move forward, there's some steps that we need to do to safeguard, knowing that, hey, private equity is probably going to get in more. When it does come in there, we got to safeguard it because I think it's going to have more of an increased role. I don't think that we can go the other way with the value-based movement, like going for government support. I don't see it.
There's plenty of money going into healthcare. The question is how to keep it moving forward. I was just wondering and again, we seem to be talking a lot about AI, and it's sort of like talking about computerized. We used to talk about computerizing healthcare, and now we just know that computers are everywhere. I mean, AI, I think, is going to wind up being there as well. But what I'm finding, just being about 2 weeks into using ambient AI, now I'm still having a conversation with the patient. I still have the computer open, but very often what I'm able to do is query someplace in the medical literature about something we're talking about, so I know I'm providing the best care to them. And I was just thinking about almost every primary care physician has a story about why did you go into primary care? Well, I couldn't figure out what I wanted to stop doing. You can ask almost every family doctor that, well, I love this and I love that and I love the other thing, and this was a way to keep doing everything. Most of the time as we go further in our career, you wind up focusing on one population of patients or another population of patients, and your scope narrows somewhat. But AI can potentially keep that pretty broad. And when you have specialists saying, well, we don't have time to see your patients, well, you're able to get a lot of what used to be a curbside consult from, and I think we're just at the very beginning of this. And so it's only going to get better. So I really view this as an opportunity. But as primary care, I think we need to take the lead and figure out how to work with, if somebody's going to take venture capital, it really needs to be the altruistic primary care providers to do that. Don't you think? I mean, to really, as you pointed out, if we're not, the old saying, if you're not at the table, you're on the menu. It's really important to be at the table.
It was really nice to see that you think about AI and AI implementation and you think, well, that's expensive because it is. And, it can only be done in these large health systems that have the money to be doing it. Or if there is a private equity that comes in and gives the capital to the private practice to do it. But it was actually nice to see that there was this residency program that on a shoestring budget has done it. And I do think that as these things become more available, we won't have to pay as much to implement them. But, I do think there needs to be safeguards around AI, both in terms of what AI can do, but also in terms of how much we're going to charge for AI, because I think it needs to be more democratized so that smaller practices can afford it. We're not just holding on to Suki or name your AI tool and those are the only ones available. And no, we're not making it available at cheaper levels for other people, because again, we'll get into an equity gap, right? Just like we did with EHRs. So I think, yes, primary care needs to be at the table to design. Primary care also needs to be at the table to talk about some of these ethical considerations. Like if we're going to keep raising the prices for these tools, there are certain populations that will not get the advantage of these tools. I do think it will lead to better care if done right. And so if you're having clinics that can't afford it and they serve certain patient populations, which happen to be under-resourced, underprivileged, you're going to have an equity issue again.
I mean, those were the populations that would benefit the most. Otherwise, you could potentially be driving more care. And as one of my attendings when I was a resident was taking care of a family that was rather well off. And I just asked him something about getting all the extra attention they were getting how did he feel about that? And he just said, the thing to remember is more care is not necessarily better care.
Better care, yeah. Yeah, that's exactly right.
I've got a magic wand question for you. If you could make one major policy change right now to improve the state of primary care, what would that be?
Oh, I think I might get in trouble for it, but I'm going to say this. I think we need to abolish the RUC and start over. I just think that it all flows from there, why primary care is undervalued. And I think if we had a better way of valuing what we do, I think it would fix everything.
And I love your answer. But for our listeners, can you just explain thumbnail of what the RUC is so everybody else will understand what you're talking about?
Yeah. So basically in our fee-for-service RVU-based system, each service is assigned, a certain amount of money, as we know. And how that is decided is basically up to a group of physicians called the RUC. And there isn't necessarily equal representation within the RUC for all specialties. And what I'm talking about is particularly primary care being left out. There are primary care physicians there, obviously, but not at, if primary care is a third of our workforce, a third of the RUC is not primary care. So it's not proportional. And the way they set the values is based on essentially, it's more complicated than this, but it's based essentially on a survey that is given to this group of physicians to say, how long does it take you to do this service, this service, this service? And there's inherent bias in there. I was surprised when I found this out. I really thought there were like health economists doing research to set, RVUs up. I was like, it's just a group of physicians sitting around the room saying how much they think things should be valued at. And I know I'm simplifying it, but that's the simple answer of what the RUC is. And I think there needs to be a better way to value what we do in primary care.
So for the students who are listening, right, the passionate students, if there's so many of them who are passionate about family medicine, especially, family medicine in particular, outside of everyone else in primary care, like what are some of the most important things that you would encourage them to do to help advocate for a stronger primary care system?
Yeah, be examples at your medical school. You guys love primary care. You love family medicine. You have realized what the beauty of family medicine is. Not a lot of your colleagues have, but you are influential. I think peer pressure is so important in medical school. So, share your stories with them, why you love family medicine. What did you see in the family medicine clinic that made you choose family medicine? Not everyone gets the same experience during their rotations. I think that is the number one thing they can do. But number two, I think it's hard to advocate as an individual. So join the AAFP. There is obviously, we have an amazing government relations team that does a lot of grassroots advocacy. It makes it easier when you're a medical student to join an association, because honestly, they just send you the emails, form letters, and say, hey, you want to advocate for Medicaid? Send this to your congressman. You don't even have to put in the work. Here's the email for your congressman. Here's, what you need to say. Just sign your name to it. And I think for medical students that really want to advocate for primary care, but don't know how to do it, don't have the time to do it, I think joining these larger coalitions is important.
Dr. Jabbarpour, thank you so much for taking time out today to talk with us. So always a pleasure to have you on.
Always a pleasure to be here. Thank you both.
What are your thoughts on Primary Care Scorecard, the cost of neglect? You've heard ours. Now we want to hear yours. Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.